This becomes visible on the elderly person's body days before death. Hello, I'm Dr. Rafael Santos, and welcome back to Integral Health. Today, we are discussing one of the most sensitive, yet critically important subjects that families and caregivers face when dealing with advanced age and chronic illness: the physical reality of the end of life. This is not an easy conversation, but I promise you, clarity is the greatest comfort we can offer in these final stages. The topic we must confront head-on is the question that haunts every caregiver. What are the specific physical changes that become visible on the elderly person's body days before death? There are many myths surrounding this process, misconceptions that cause enormous unnecessary anxiety and guilt. My job as a geriatrician is to peel back the silence and explain the clinical facts so that you can recognize natural progression versus a crisis. Let's start with why this is so terrifying. We spend a lifetime avoiding the reality of death, and when we are suddenly faced with profound, rapid physical changes in someone we love, our immediate instinct is panic. We assume we failed, or that these sudden signs demand immediate, aggressive intervention. I remember vividly a call I received late one Sunday night. It was John, the grandson of Mrs. Helen, an incredible woman I had been caring for, who was in the advanced stages of congestive heart failure and Alzheimer's disease. John was the primary caregiver, a dedicated man struggling under the weight of his responsibility. He called me, his voice tight with desperation. "Doctor, I don't understand. This morning she took a few sips of broth, but tonight she just looks different. Her skin, it's cold, and there's a strange, patchy, purplish discoloration starting on her knees and spreading down her legs. It looks like marbling, doctor. Is she in pain? Did I do something wrong? Is this a sign that I waited too long to call the nurse?" John, like so many of you who are watching and caring for your loved ones, was terrified because he saw a physical sign he didn't recognize. This change, the mottled bluish-purplish marbling he described, is a phenomenon known clinically as livedo reticularis, or more simply, mottling. And while it is disturbing to see, it is perhaps the clearest, most undeniable physical sign that the body's circulatory system is beginning its final natural shutdown. When the heart, which has been working tirelessly for 90 years, begins to fail completely, it starts to prioritize blood flow to the most vital organs: the brain, the lungs, the core. It pulls circulation away from the peripheral areas: the fingers, the toes, the extremities. This lack of oxygenated blood causes the skin to cool and adopt that specific, frightening pattern discoloration. I explained to John that this was not a medical crisis we needed to rush to the hospital for. This was the body, in its wisdom, making its final adjustments. It was a sign of peace, in a way, because it meant we needed to shift our focus entirely from curative measures to comfort measures. I told him, "John, you're doing nothing wrong. This is the body letting us know it is tired." And that is why we are having this discussion today. When you see these changes, the strange coloring, the sudden refusal of liquids, the shifts in breathing, it is easy to feel overwhelmed by guilt and fear. You think, "I must intervene. I must force feed. I must call the ambulance." Let me be direct. Watching the decline of a loved one is one of the hardest things any human being will ever endure. Your fear is completely valid, but that fear often stems from a lack of clear information about what is normal in the process of dying. We cannot fix what is inevitably concluding, but we can manage the symptoms and provide dignity. My promise to you is this: we will look clearly and without medical jargon at the three most critical physical systems that signal imminent decline. We will discuss exactly what the skin looks like, how the breathing pattern changes, specifically the Cheney-Stokes respiration that frightens so many people, and what the changes in urination and hydration really mean. By the end of this conversation, you will be equipped with the knowledge to look at your loved one, recognize these signs, release the guilt, and understand that these visible physical changes are not a failure of care, but simply the final, quiet, orderly transition. This knowledge allows you to focus your energy entirely on providing comfort, love, and presence in those extremely precious final days, rather than chasing interventions that will only prolong discomfort. Stick with me. This is vital information for maintaining the dignity of life until the very last breath. We ended our last segment discussing the immense value of focusing energy on comfort and presence in those final, precious moments. To do that effectively, we must understand exactly what the body is doing when it begins the process of shutting down. Knowledge replaces panic. I'm going to be extremely clear and direct here, because this is the medical reality that often frightens families the most. What is happening in the final days and hours is not an unexpected failure of a single organ, but rather a coordinated systemic conservation of energy. Think of it this way: the body is making a final strategic decision about its resources. It decides that maintaining peripheral systems, things like the ability to digest food, to move the limbs with strength, or to maintain perfect skin temperature, is no longer a priority. The only priority now is preserving the central core, the heart, the lungs, and the brain for as long as possible. The visible signs of this conservation effort often begin days before the final breath, and they are frequently misinterpreted as signs of extreme suffering or a sudden catastrophic new illness. Let us discuss the most significant visible sign, which directly addresses the title of our talk today, the change in circulation and appearance of the skin, specifically in the extremities. As the body conserves energy, it begins to withdraw blood flow from the hands, feet, arms, and legs. This redirection allows the blood, warmth, and oxygen to stay closer to the central chest cavity. What do you observe? First, the hands and feet become noticeably cooler to the touch. This is a very common sign, but following this, you may start to see what we call mottling. Mottling is the appearance of a marbled purplish or bluish-red pattern across the skin, especially on the feet, lower legs, and sometimes the arms. It looks like an irregular network of lines. Medically, this is called levato reticularis. I want to be precise. Mottling is a clinical sign of severely reduced peripheral circulation. When it begins to track up the limbs, moving from the feet up the legs, for example, it signals that the circulatory system is struggling to maintain even basic function. It is a very strong, reliable indicator that the final stage of life is upon us. And here is the crucial takeaway for the caregiver. This physical manifestation, this mottling, is not inherently painful. It is a passive physiological event. Your response should not be to try aggressive warming or to panic. Your response should be to ensure dignity, gentle blankets, soft touch, and focused pain management if any discomfort is present, not interventions designed to fix the circulatory system. At this stage, trying to reverse this process is futile and often causes distress. Now, let us turn to the internal processes that are slowing down, specifically focusing on the relationship between medication and a failing body. This brings us to the serious issue of polypharmacy. Polypharmacy, simply put, is the routine use of multiple medications, often 5 or more, sometimes prescribed by different specialists who are not communicating with one another. When an older adult is stable, their liver and kidneys, the body's main chemical processors and filtration systems, can usually handle this chemical load. But as the end of life approaches, these processing centers slow down drastically. The body goes into a state of semi-starvation due to lack of appetite and hydration, and the organs become sluggish. The half-life of many medications, the time it takes for the body to eliminate half the dose, increases dramatically. The consequence is alarming. Medications that were perfectly safe 6 months ago can accumulate in the system and become toxic burdens. A blood pressure pill, for example, might drop the blood pressure too low, causing dizziness or nausea. A diuretic, meant to pull fluid off, might now dangerously dehydrate the person, worsening their comfort. This is why one of the most compassionate and medically sound steps we take in the final phase of life is called deprescribing. We must strategically remove medications that are no longer serving the immediate goal of comfort. We are no longer treating prevention, we are treating dignity. Does the statin, used to lower cholesterol and prevent a heart attack 10 years from now, matter today? Absolutely not. Is it potentially causing GI upset or muscle weakness? Yes. This is the point where the family must have a direct, honest conversation with the physician about simplifying the drug regimen. The goal shifts from adding years to life to adding comfort to days. Here is the geriatric truth. Aging is defined by a loss of physiological reserve. Think of reserve as your body's safety net, its ability to bounce back from stress. In a young person, that net is deep and strong. They get the flu, they recover completely in a week. In the final phase of life, that reserve capacity is essentially exhausted. The elderly person is operating at 95% capacity just to sit quietly. Any stress, a small cold, a minor change in routine, or a medication adjustment can push them into a rapid decline. This decline is often mistaken for a treatable illness, but when we see a cluster of signs, reduced appetite and thirst, increased sleep, detachment from the environment, and the circulatory changes we discussed, it is rarely a new disease. It is the convergence of the aging process with the underlying terminal condition, whether that is heart failure, advanced dementia, or cancer. The increased sleep is the body conserving energy. The lack of hunger is the body preparing for a natural fast. The digestive system is not receiving blood flow and cannot process food anyway. Trying to force food or hydration at this stage does not prolong life. It often leads to discomfort, swelling, or aspiration. Understanding this difference allows you to stop chasing interventions and instead become the protective barrier that surrounds the patient with peace and comfort. We are not treating the symptoms of an illness anymore. We are honoring the process of life completion. In our next segment, we will tackle the emotional and spiritual dimensions of these changes, discussing communication and presence, and how to speak about death in a way that respects the person's entire life journey. Stay with me. We have navigated the difficult truth about the physical changes that signal the final stage of life. Now, we must transition from understanding those signs to implementing a clear, compassionate protocol, a detailed roadmap for ensuring dignity and comfort in the final days. This is not passive waiting. This is active comfort care. If you are a caregiver, or if you are preparing your own advanced directives, these are the practical steps you must internalize. This protocol is divided into 3 critical areas: environment, comfort management, and communication. Environmental protocol: creating a sanctuary. The physical surroundings have an enormous impact on comfort and anxiety, especially as awareness begins to ebb and flow. The goal is to minimize stimulation that causes agitation and maximize sensory reassurance. 1. The bedding and positioning. The person will likely spend 90 to 100% of their time in bed. We must manage the risk of skin breakdown and breathing difficulty. Mattress. If possible, acquire a specialized pressure-reducing mattress, alternating pressure, or air mattress. This prevents the deep, painful ulcers that can form rapidly when mobility is gone. Positioning. Avoid keeping the person flat on their back. Elevate the head of the bed slightly, about 30 degrees, to assist with breathing and swallowing, and to reduce the risk of aspiration. Use pillows or wedges to position them on their side, the recovery position, and alternate sides every 2 to 3 hours. If they are sleeping comfortably, however, do not wake them just to turn them. Comfort takes precedence over schedule. Linens. Use soft, breathable cotton sheets. Wrinkles in the sheets, which you may barely notice, can feel like boulders to someone whose sensory input is now focused entirely on the point of contact with the bed. Check and smooth the sheets frequently. 2. Sensory adaptation. The world outside must become gentle. Light. Keep the room softly lit. Harsh overhead light can be distressing. Use warm indirect lighting like a bedside lamp. If they are sensitive to light, gentle darkness is fine. Sound. Low, constant noise is better than abrupt silence. Soft music, familiar calming melodies can be therapeutic. The television should generally be turned off or muted, as sudden noises or rapidly changing images can trigger confusion or agitation. Temperature. Maintain a moderate, comfortable temperature. Often, the person may feel cold due to circulation changes, which contributes to the skin mottling we discussed. Use light blankets for warmth, but never heavy covers that feel restrictive. Check for signs of overheating, which can increase restlessness. Comfort management protocol. Pharmacological and non-pharmacological care. When we move into the end-of-life stage, our medical focus shifts entirely to pain and symptom control, known as palliative care. 1. Managing pain and restlessness, pharmacological care. Pain is not always visible as a grimace. It can manifest as agitation, inability to settle, or labored breathing. Proactive pain relief. Do not wait for the person to ask for medication. As consciousness fades, they lose the ability to articulate their needs. If they have been on chronic pain medication, continue it regularly. Discuss a comfort kit with the hospice or palliative care team. These kits typically contain medications for pain, opioids, anxiety, anxiolytics like lorazepam, and severe nausea or restlessness. The myth of addiction. We are no longer worried about addiction. If pain is present, relief is the moral imperative. Giving morphine or similar medications does not hasten death when used appropriately to treat symptoms. It provides peace. If breathing becomes rapid and shallow, low-dose opioids can paradoxically make breathing easier by reducing the body's distress signal. Managing secretions. The death rattle. This sound is often more distressing for the listener than for the patient. It is caused by the inability to swallow or clear normal salivary secretions pooling in the back of the throat. Do not suction the throat. This is painful and ineffective. Instead, administer anti-secretory drugs like scopolamine or atropine drops, as prescribed. Position the patient gently on their side to allow gravity to help drain the fluid. 2. Hydration and nutrition. The critical shift. This is perhaps the hardest instruction for caregivers to accept, but it is necessary for comfort. The natural cessation of appetite. Loss of appetite and thirst is a natural protective mechanism. The body is conserving energy and signaling that it no longer requires nutrition to sustain life. You must stop thinking of food as medicine now. Force feeding or aggressive pushing of fluids causes discomfort. The danger of artificial hydration. Aggressively providing IV fluids, IV drips, often does more harm than good in the final days. Fluids at this stage often pool, leading to edema, swelling in the extremities, and critically, increased secretions in the lungs, making breathing more difficult and potentially causing greater discomfort. Practical comfort. Focus only on mouth moisture. Use soft sponges called touthettes, or wet gauze swabs dipped in plain water or glycerin solution to gently moisten the lips, tongue, and inner cheeks every hour. This addresses the feeling of dryness without overloading the system internally. 3. Skin and oral care, addressing the physical signs. As circulation slows and the mottling, purplish discoloration appears, specific care is needed. Mottling. And when you see mottling, circulation is failing. Massaging these areas vigorously is discouraged as it can damage fragile tissue. Instead, apply gentle, moist, warm compresses if the patient expresses feeling cold, focusing on areas that are not discolored. Mouth and eyes. The eyes may appear dry or slightly open even during sleep. Apply artificial tears to prevent corneal dryness. If the patient wears dentures, remove them to promote comfort. If they wear glasses, keep them nearby. Communication and presence protocol. As a loved one becomes unresponsive or minimally conscious, it is easy to assume they cannot hear you. Scientific and experiential evidence overwhelmingly suggests that hearing is the very last sense to fade. Your presence and voice remain anchors. 1. The power of your voice. Speak simply, clearly, and close to their ear, using a normal tone, not a whisper, which can be alarming. Validation and memory. Share positive memories. Talk about love, about the impact they had on your life. This is not the time for discussing finances or arguing about external issues. This is the time for connection. Giving permission. This is perhaps the single most important communication act. Many people linger because they fear leaving their loved ones sad or unresolved. Say clearly, "It is okay to go. We love you. We will be okay." Repeat this message often. Reassure them that you are present and that they are safe. 2. The power of touch. Touch remains vital even when verbal communication is gone. Gentle contact. Hold their hand, stroke their forehead, or lightly rub their arms. Check if they flinch or show signs of discomfort before continuing. If their presence is still, the warmth of your hand can be deeply comforting. Group presence. If several family members are present, ensure only 1 or 2 people are speaking at a time. Too many voices can be confusing and overwhelming. Silence, accompanied by loving touch, is often the most profound form of communication in the final moments. This detailed protocol ensures that the person's final chapter is marked not by fear, but by peace, dignity, and unwavering love. This is not about battling the inevitable. It is about honoring a life well lived until the very last breath. If you are walking this path, remember that confusion, restlessness, and withdrawal are symptoms, not personality traits. Approach every practical intervention with the question, does this increase comfort or does it prolong suffering? The focus must always be on comfort. In the next segment, we will address the caregiver's needs, focusing on how to manage your own grief during this period of active caring, and how to utilize the hospice system to its maximum benefit. We have covered difficult ground today, perhaps the most critical conversation we can have regarding comprehensive health and the journey of life. I know these topics are heavy, but facing them with clarity is the truest form of love and preparation. Let's recap the central truth we must always return to. When we observe the definitive physical signs on the elderly person's body, the mottling of the skin, the profound slowing of respiration, the loss of interest in food and drink, our purpose shifts entirely. This is the body communicating its natural process of closure. We must be direct once more. At this stage, the focus is not on forcing the body to continue living through aggressive means. The focus is exclusively on comfort, maximizing peace, and safeguarding dignity. We are optimizing the remaining moments, not fighting the inevitable passage. Dignity is a word we use often, but what does it truly mean in the final days? It means honoring the person, not just the diagnosis. It means allowing them control over the small things they can still manage. It means ensuring they are free from pain, which often requires adjusting pain medication schedules proactively, anticipating their needs before they can voice them. And crucially, dignity means giving them permission to let go. I see this frequently. The elderly patient holds on, fighting the process, because they are deeply worried about the pain and grief of their loved ones. They feel a responsibility to stay. Your presence, your gentle touch, your honest, loving words are the greatest medicine you can offer now. Tell them it is okay. Tell them how much you love them, that you will be all right, and that they have earned their rest. This act of releasing them from the burden of your grief is perhaps the greatest gift you can give them in their final moments. To the sons, daughters, and spouses watching, you are navigating the hardest, most sacred act of love imaginable. You are witnessing the end of a chapter, and your grief, this heavy, anticipatory sorrow, is completely valid. Do not try to be the hero who handles everything perfectly alone. Utilize the systems designed to support you. We spoke about hospice care, and I want to emphasize that hospice serves the family unit just as much as it serves the patient. Lean on their expertise in pain management, and, more importantly, lean on their emotional and spiritual support. You cannot pour from an empty cup. Taking moments for yourself to breathe, to cry, to eat is not selfish. It is mandatory for you to maintain the compassionate care your loved one deserves. We, in medicine, often use the language of battle. We say someone lost the fight. But when life reaches its natural, peaceful conclusion, there is no defeat. There is immense strength and peace in acceptance. Our role is to facilitate that transition with wisdom and unwavering empathy. The metric for success is not longevity. The metric is the quality of those final days. Are they pain-free? Are they surrounded by love? Do they feel safe? This entire conversation about end-of-life signs and preparations defines what we mean by integral health. Health encompasses the full arc of existence, from the first breath to the last. Our responsibility is to accompany those we love with clarity, wisdom, and profound kindness until the very end. If this video has helped you prepare for these difficult conversations, or provided you with even one moment of clarity, please share it. You might give someone else the courage to ask the direct questions necessary to ensure their loved one passes with the dignity they deserve. If you are new here, subscribe to Saudi Integral for more evidence-based, compassionate guidance on geriatric health and longevity. Hit the notification bell so you don't miss our next essential segment, where we will dive deeper into managing caregiver burnout and utilizing advanced directives effectively. Thank you for trusting me with this important discussion. Take care and be well.